Great. Well, thank you so much. And it's really a pleasure to be here. Thanks you to the SCCT for inviting us. Today, we're going to talk a little bit about staging and classification of coronary artery disease, specifically with AI quantitative coronary angiography. So agenda for today's talk is here. We'll talk a little bit about coronary CT and atherosclerosis. Then we'll talk about how does Cleerly's AI QCT software service work, and then we'll specifically talk about coronary artery disease staging with the new, most recently published classification system that was in the JCCT a couple of months ago. I think many people, I'm sure, on the webinars is quite familiar with heart disease and heart disease trends, but many of us found it somewhat disturbing the fact that despite all of the significant gains in therapy, medication, intervention that have occurred, that in the last couple of years, there's actually been an upward deflection of deaths from cardiac disease in the United States, as you can see here. So this is something that many of us would very much like to turn around and get that trend line going back down and getting it as close to zero as we possibly could. And we think that coronary CT is a way to get us there. We know that coronary CT has come a long way in the past almost 20 years. I personally was a little bit of an early adopter of coronary CT, did my first cardiac CT study on a 16-slice scanner clinically back in 2003, so coming up in almost 20 years for that. But nowadays it's come a long way. We can get whole heart coverage in less than 1 second with some of the newer broad detector scanners. The radiation dose that we struggled with so much in the early years of cardiac CT has now come down to, most centers with prospective gating and a reasonably new machine can have average radiation doses of only 1 to 3 millisieverts, which are very acceptable. And of course, the spatial resolution has continued to improve and will improve. The first few years cardiac CT was around, we were all very focused on trying to look at stenosis and sort of repeating what we were already able to do with invasive angiography. And then for a few years, many people pivoted to trying to see if we could use coronary CT to define the presence of ischemia as we do with other stress tests. But the last few years, a lot of the emphasis has been primarily placed on the detection and characterization of atherosclerosis, which is what we're very much focused on. Ischemia and stenosis are, of course, still important, but we believe atherosclerosis is the most important thing that we can gather these days from the cardiac CT examination. Invasive angiography was our gold standard, and many still think is for many years. However, what invasive angiography doesn't do for us is really tell us about the atherosclerosis. It may tell you something about stenosis, but as you can see on the CT image that, you can have pretty substantial plaque, and even a plaque that has a particularly bad phenotype in cases where you have a normal or near normal invasive angiogram. And of course, the added benefit is that it's a non-invasive test to look for that plaque instead of an invasive, more expensive modality with higher morbidity and mortality. But again, we've made a lot of strides in the last few years, many of which thanks to the advocacy of the Society of Cardiac CT. Coronary CT angiography is now endorsed and it attained level 1A recommendations in last year's AHA-ACC chest pain guidelines, above that of other types of stress testing. We know that it can be quite effective. In the Scott Hart trial, we found that, but judicious use of cardiac CT and then acting upon the atherosclerosis depiction from CT, you can actually reduce fatal and non-fatal MIs by more than 40%. We also know that it's safe. Our doses in many cases can approach that of mammograms with new technology. And of course, it's a very rapid modality. You can acquire the entire heart, again, with newer scanners in less than a second, and also very limited time in your CT scan room. So we've come a long way. What we've also learned in the last number of years was that, we can take those CT images and we can cut into them and look at the atherosclerotic plaque itself. And we've learned that atherosclerotic plaque is not one type of plaque. There are actually many different types of plaque, and they represent a continuum of imaging appearance on CT, which also is a continuum of risk to the patient. So if you look at the very highest category here, where we see the darkest plaque in the center, this is the CT equivalent of a necrotic core. This is a plaque that has high lipid content, and then we can go to fibrofatty content, and then eventually calcified content. We know that those high-risk plaques connote the highest risk to the patient, and they can be the culprit lesions at MI. The lowest risk plaques are much more stable, the calcified ones, and there's a continuum of risk between the two. But we've also learned that we can stabilize these plaques with medication and diet and exercise. So how does our technology work? We work after the CT is acquired. We recommend that the studies are performed according to the Society of Cardiac CT's recommendations. The studies are then uploaded to the cloud. We then process them and return reports to the imaging physician, as well as we have clinically facing reports both for the provider and for the patient. We report stenosis of all coronary arteries greater than 1.5 millimeters. We have a CAD-RAD solution for those also. And then we also look at all of the atherosclerotic plaque characteristics. That is the total plaque volume, as well as the percent atheroma volume, the amount of calcified, non-calcified, and low-density plaque, as well as remodeling index, and the presence of two-feature plaques. Here you can see traditionally we do stenosis severity just like everybody else does, where we look at a diameter stenosis. We also do report area stenosis. And then we look at all of those plaque characteristics on both a per plaque, a per segment, a per vessel, and a per patient scale. So we can look at the total plaque volume, the low density plaque volume, the non-calcified plaque, and the calcified plaque volumes, as well as the remodeling index. And the remodeling index, for those of you who may not know, is just a ratio when the plaque bulges outward. It's a ratio of the outward lumen wall to that of the more proximal normal lumen diameter. So it's a measure of outward bowing of the artery because of plaque that's inside. And the presence of outward remodeling and the low density plaque is what we refer to as high risk plaques or two-feature plaques. Our software, we want you to upload all of the series that are available, and we take the two best series for further analysis. The 6 different machine learned algorithms do that, as well as place a center line. They then name all of the coronary segments, as you can see here. We have an algorithm that then determines the boundary between the lumen and the plaque and the epicardial fat. And then everything between those two boundaries are classified as plaque, and then also further classified as being different types of plaque based on their Hounsfield attenuation. All of that data is then curated over here on the right side of the screen. And then we have another reporting software that actually takes that tremendous amount of data and sort of simplifies it down into a summary page, as you can see here, that lists stenosis severity, plaque quantities, CAD-RAD score, as well as a diagram of stenosis by individual segment. And you can sort of click through this and get much more granular information and dynamic information about the morphology of the vessels and the degree of stenosis. We have a page specifically for all of the atherosclerotic data that you will need. We have a stenosis page that looks at stenosis on a per segment basis that can also be drilled into. CAD-RAD's reporting page. We have a quantitative page that lists the great deal of quantitative information. We have 37 different parameters that we report. This is really not intended for clinical use, but more so for those of you doing research. It can be downloaded. We then have a full text report that is generated under how the SCCT guidelines like us to do it. Then we also have a comparison page. So if we're comparing 2 studies to see if there's any change, we can actually line those 2 studies up, and we'll report on a per patient, per vessel, and even a per plaque basis how changes may have occurred within the plaques in the intervening period of time. We have a report which is dedicated really for the provider. This can be ingested into the electronic medical record, summarizes all of our findings, as well as gives limited images of the vessels. And we even have a patient-facing report that has about 20 pages of educational data written in 5th grade language so that people can understand what coronary artery disease is, why plaques look different, why plaques change with therapy, and then we actually show them their images themselves. So this is sort of a patient-facing report. So that's what Cleerly is and what Cleerly does. We specifically evaluate the amount and type of coronary atherosclerosis that's there, and then we have multiple ways to present it to the diagnostic imaging physician, the provider, and the patient, so that everybody in the chain knows what's going on, and then we can even track disease for those physicians. So for coronary artery disease, coronary atherosclerosis risk has not been, staging system has not previously existed for coronary atherosclerosis. There's lots of other staging systems that are out there, but coronary atherosclerosis is very important. We know the plaque phenotype is the strongest discriminant of future risk of major events. But to date, nobody had, or at least until recently, nobody had described a staging system for coronary atherosclerosis, and it was felt that one needed to exist. I think everybody understands that there's lots of staging systems out there for both neoplastic and benign diseases. Lung cancer staging is quite familiar to many of us. Liver damage stages, colon cancer. There's even staging system for arthritis, but staging system has not existed for coronary atherosclerosis. Staging systems are generally used for a number of different purposes. On the left here, in breast cancer, a staging system will define prognosis, right? So if you're at the lowest stage, you're going to have the best prognosis. If you're at the highest stage, you're going to have the poorest prognosis, unfortunately. But people will put people into different stages specifically in order to be able to more accurately discuss somebody's prognosis with them based on their imaging findings. It can also be used for therapy. So again, a little bit complicated in this case of breast cancer, but depending on your stage, whether or not you get adjuvant therapy or surgery or radiation or chemotherapy is all based upon the stage that you are. So staging systems are clinically useful for both prognosis as well as for determining the type of therapy that a patient would receive. Previously, there are some types of heart disease stagings out there. There's, heart failure staging that many people are familiar with. There's staging of aortic stenosis. But if you look at coronary artery disease or atherosclerosis, there's not actually a staging system that's been previously described. If you Google it, you'll see images like this that don't really describe a staging system like we see for all these other disease processes. They actually describe sort of a evolution of coronary atherosclerosis as stages, but this is not a clinically useful staging system that describes, different stages that can be used for either therapy or for prognosis. We do, for coronary artery calcium scoring, there is a staging system that many of us are familiar with. Calcium score of 0, has no calcified plaque, a score of 1 to 10, 11 to 100, 101 to 400, and over 400 actually will give you minimal, mild, moderate, and extensive plaque burden. So this is a staging system that exists, and this staging system is actually used. You can actually use it to determine prognosis for the patient. So risks do correlate with the amount of calcified plaque that's present. On the right-hand side, you can see that, and this is from Australia and New Zealand, that they did use the calcium scoring in part of their therapeutic decision-making. Here in the US, the AHA-ACC, under their primary prevention guidelines, do include some use of coronary artery calcium scoring for their guidelines. But unfortunately, previously, there hasn't been one specifically that looked at coronary atherosclerosis. So there was a paper published, which I was a co-author a couple of months ago in JCCT, which Jim Min was a primary author. So in this paper, they looked at a cohort of patients from the Credence trial in order to determine a staging system which used both the data from credence, which showed the degree of coronary atherosclerosis from quantitative CT. They also knew the degree of stenosis using quantitative coronary angiography. And most of these patients had 3-vessel FFR performed, so they also knew the presence and extent of ischemia. So using this data, we tried to determine a plaque staging system in which aside from stage 0, which had no atherosclerosis, the mildest cases of non-obstructive disease were in the first stage, and the most significantly ill patients, the patients with the most ischemia and stenoses, went to stage number 3. So we were able to distribute that data, and you can see that we were able to define a stage 1, 2, and 3, and this is the distribution. As it turns out, we also wanted to use relatively easily to remember numbers for the staging system, just like there is with coronary artery calcium scoring, in which it's 0, 1 to 10, 11 to 100, 101 to 400, etc. For this staging system, we did actually have some easy to remember thresholds, and we defined it 2 ways. One was using absolute plaque volumes of cubic millimeters, and the other was to use percent atheroma volume. So when we broke it down, it was greater than 0 to 250 cubic millimeters would be defined stage 1, greater than 250 to 750 cubic millimeters stage 2, and then greater than 750 cubic millimeters for stage 3. And you can see when you define the staging system like that, here most of the multi-vessel obstructive disease is in stage 3, and there's significantly less of it in stage 1, and of course none of it in stage 0. Ischemia, or patients with ischemic vessel segments, were also distributed in a similar manner, where the most ischemic patients were in stage 3, none in stage 0, and a minimal number in stage 1. So these are the thresholds that were determined for the staging system. It can be reported as either total plaque volume or the percent atheroma volume. So the percent atheroma volume, for those of you who may not be as familiar, that is a number in which you take the total plaque volume in cubic millimeters, and then you divide it by the volume of all the patient's epicardial coronary arteries. So in essence, it gives you a percentage of how much of the coronary arteries are plaque. So in the case of 15%, a PAV of 15% of the volume of the arteries are plaque. In the probably 5,000 or 8,000 patients I've now seen using our software, we see up to about 30, maybe 35% atheroma volume in the very sickest patients. So that would be an extreme example. Most of it, of course, is well below 15%. The other issue just to discuss here, and we've had people ask this question, is, well, what if PAV and cubic millimeters of plaque don't always line up? So if one is above the threshold and one is below, you should choose the higher of the 2 stages between the 2 examinations. So here's a clinical example of somebody with stage 0 disease. We didn't pick up any atherosclerosis at all, so they're stage 2, lucky them. Someone with some mild disease, we can see there's a little bit of plaque here in the obtuse marginal. Total plaque volume is 62 with a PAV of 1.2%. So this would be stage 1 disease. Another patient now with some more disease, almost 500 cubic millimeters of plaque and a PAV of 12%. So this patient would be stage 2 disease. You'll notice in this case, there is a moderate stenosis, but the staging system is actually independent of stenosis. The staging system only accounts for the degree of the volume of atherosclerosis, but not any concurrent stenoses that may be present. And finally, a patient with very extensive disease here in the LAD. This patient does have multiple stenoses, but in this case, their plaque volume was 1,800, well above that 750 threshold, and their PAV is 30%. So this is really the highest category of disease that we will see. So summary of the staging system on the left. When we applied this data to a group of patients from the Clarify-1 study, sort of distributed this way where, stage 0 patients were, were about 20%. The majority of people, and these were all symptomatic patients at 3 centers who presented for coronary CT based on symptoms. The majority of people were in stage 1. About 12% of people were stage 2, and about 3% of patients were stage 3. So sort of how you would expect it to distribute out clinically. Again, very dependent on the population and age of the patients that you may be looking at. So how can the staging system be used clinically? So if we look at guideline-directed medical therapy, generally there's 3 options with, there's no therapy, reassurance to the patient if they don't meet certain criteria. There's sort of the basic medication level, and then there may be multiple or intensive medications depending again on patients' risk scores and other clinical parameters. So, at times that would line up quite nicely with the staging system, in which case nothing would change. However, we know at times where people don't meet the guideline limits for disease, but we know that their atherosclerotic burden is actually there. So in this case, you may take someone who the guidelines would say does not merit medication, but in fact, since there is atherosclerosis present, you may make the decision to actually go ahead and put that patient on medication or other therapies. And of course, there's always those patients who, despite not meeting, LDL or other cholesterol guidelines, may have significant atherosclerosis, in which case their medication would be potentially multiple medications or certainly intensified. So this would show that in certain situations, we may have a net reclassification based on the staging system to intensification of medical therapy from patients who weren't necessarily initially targeted to receive that. Of course, the same way patients on basic medication according to guidelines may in fact have no atherosclerosis. And in those cases, you may have shared decision-making to just judiciously de-intensify or take the patient off medication. That would be an individual process or decision for the patient and the referrer. Of course, they may line up quite nicely with what the guidelines are showing them. And there may, of course, also be more advanced disease than basic medication would handle, in which case they may be a net intensification. And finally, patients are de-intensification in the case with, as we talked about initially. Finally, patients who, would, according to guidelines, have the most significant intervention. In fact, if you image them, they may in fact have no disease. And we've all probably seen cases like that, in which case the medication may be potentially de-intensified, or they may receive a more basic medication, or of course stay where they are. But there may be a net de-escalation of therapy based on this group of patients. So overall, the thought with this staging system is that patients who have atherosclerosis, the atherosclerosis itself is the strongest predictor of future cardiac events. It's not necessarily the patient's cholesterol levels or other clinical parameters. In studies that have looked at this, it is the actual plaque itself. So based on the amount of plaque that's there, it may be more prudent to dispense medication based on the plaque. If there's no plaque, then you can either stick with guideline-directed medical therapy based on their other clinical parameters, or potentially you could de-intensify that and reassure the patient. Again, that would be an individual decision for the provider and the patient to be made together. Patients who are in stage 1 would probably benefit from the least intensive medication. For example, statins would be appropriate in this group. Stage 2 may require more moderate and moderately intensive medications, such as high-intensity statins and or some other medications. And of course, stage 3 disease, which is less than 10% of patients, would probably benefit from the most intensive medication regimens. Nowadays we are quite blessed with the number and efficacy of the many different medications which have come out in the last 5 to 10 years. We do anticipate that there will be some guidelines or expert consensus document coming out that will use the staging system to actually make specific recommendations in patients using a combination of both their clinical risk, those are with high cholesterol, diabetes, and other conditions. And that would be used in conjunction with their plaque stages to come up with specific medication recommendations. And then these patients could then be tracked over time to see if those medications are actually effective or not. And if they are effective, wonderful, they can stay on the medication regimen. If they're not effective, then it may be appropriate to intensify the medication or change it at that time. So that's it for our plaque staging system. The artificial intelligence quantitative coronary CT really, for the first time, enables a plaque staging system based on the quantity of plaque that's there. We know through some of our evidence that clinical readers don't do a great job of quantitating the amount of plaque that's there. There's a great deal of inter-reader variability, so we're really not able to accurately visually put patients into staging, but we are able to do it using quantitative CT methods. We believe that these are clinically relevant plaque stages and thresholds based on our analysis of the trial published in JCCT, where we really did understand, we correlated the amount of plaque that was present with the patient's coronary stenoses by QCA, as well as the presence or lack of ischemia from invasive FFR. The staging system does have some easy to remember thresholds, 0, 250, and 750 when you're looking at absolute plaque quantities, or 0, 5, and 15% if you're using percent atheroma volume. And again, if one is telling you the patient's stage 2 via 1, but stage 1 via the other number, then I would select the higher of those two. We think that this staging system will be very useful for prognosis. Other studies have shown that the more plaque you have, the poorer your prognosis will be. So I'm sure that evidence will show that increased staging also correlates with poor prognosis, and we have some planned publications along those lines in the near future. And we also think it will be useful for determination of treatment strategies, right? Sicker patients need more medication, just like all the other disease processes that we're familiar with. The more advanced your disease stage is, the poorer your prognosis will be, the more and stronger medication you would potentially benefit from. And that we do anticipate there'll be some atherosclerotic disease treatment algorithms that are based upon this staging system, as we discussed today. Hopefully we know that those are currently undergoing peer review in the literature, and hopefully those will be out to guide us all to using these staging systems in the near future. All right, I think that is it for the lecture. I think I'm going to stop my share. I think we can click over to do some Q&A now.
Thanks, Jay. We have 2 questions. What would you recommend using CCTA/CAD staging as an alternative to CAC screen?
That's a great question. I think Jim or Min, are you on? I think I was just messaged that you were here. No.
Jay, can you hear me?
Yes, we can hear you. Did you hear
sorry.
the question?
Maybe could we repeat it one more time?
Of course. Would you recommend using CCTA or CAD staging as an alternative to a CAC screen?
Yeah, that's a really good question. Like, so the, I think that when we had the introduction of calcium scoring, I think it was the late 80s, like it was definitely a big step forward. It allowed us to visualize atherosclerosis, albeit just calcified atherosclerosis. And when you look at the data, about 70% of the folks who show up with their first heart attack actually have normal cholesterol levels. So we know that risk factors of disease aren't, the sort of the most ideal biomarker to identify those at risk. I think it's very good for population comparisons, but not so great for personalized assessment of somebody's risk. For calcium scoring, it was definitely a step forward. When you look at the data from the large population-based studies, whether you look at MESA or Cardia or the Dallas Heart Study, even a study that we had done called Iconic, like what you see is that the calcium scores of 0 tend to be less often in patients presenting with MI. But actually, it's quite non-negligible. Like it's somewhere between 20 and 35% of people who will develop a heart attack will have had a 0 calcium score at the time of their evaluation. So the posit here is that, you know, now that we have this ability to look at all of the plaque, not just the calcified plaque, would that give you a better opportunity to identify those who might be at risk? And it looks like that's the case, right? Like from both Iconic, Confirm, from Scott Hart, from Promise, like what we know, the strongest discriminants of future heart attack risk is really that low density non-calcified plaque. So I think that we definitely need studies to evaluate the comparative effectiveness of these kinds of studies. But everything that we understand is that the darker the plaque, the more dangerous it seems to be. And so I think the more ideal approach would be CCTA pending some large outcomes data studies. So I don't know if that addresses the question.
Yeah, thank you, Jim. Another question would be, can the software help with quantitative assessment of stenosis? And I'll take that one if that's okay with you, Jim. Absolutely. You know, we believe that plaque is extremely important, and plaque characterization will be quite prognostic for our patients. However, we still believe that stenosis is an important component of diagnosing and characterizing coronary disease. So we do have some good evidence. We had a paper published in JACC Imaging this year that compared Cleerly's ability to detect significant stenoses at both the 50 and 70% level in a study of about 303 patients who had quantitative coronary angiography as well as FFR. So the numbers that were reported were quite good in that study. We had sensitivity of 94% for detection of levels of both those levels of stenoses. Specificity was about 70 to 80% in both, with accuracies in the mid 80% range and very high negative predictive values. So the study really closely correlated with that of quantitative coronary angiography. And matter of fact, the interesting thing of that study was in the patients in whom were discordant, which was about 7% of vessels, where the quantitative coronary angiography and the Cleerly analysis of the CT were differed. You know, for purposes of statistics, of course, QCA was considered the gold standard. So, you know, the performance of CT was decremented there. However, since we actually had a second gold standard of invasive FFR, and if you look at that 7% of cases compared to invasive FFR, in 2/3 of the cases, the FFR actually agreed with Cleerly's analysis and only 1/3 with quantitative coronary angiography. So we know that quantitative CA is, you know, an imperfect gold standard, and that CT has the advantages of being three-dimensional and may actually overcome some of the shortcomings of quantitative coronary angiography. However, I will say that, you know, our analysis is good, but it's only as good as the quality of the CT that we are able to process. So, you know, we strongly encourage folks who want to use our tools to, you know, produce the highest quality CTs that they can using the guidelines of the Society of Cardiac CT, good, you know, heart rate control, and use of nitroglycerin for the study. So the better the quality of the CT that is sent to us, the more accurate our outputs would be. You know, if it's a borderline or poor quality CT, our accuracy would probably be less optimal. But certainly in good cases, we do very well. So it's somewhat like how readers do. We think we outperform readers, as we showed in the Clarify 1 study, but we also, as readers do, we suffer when the image quality is poor. Let's see, I have another question, Jim. I don't know if you'd like to take this one. If someone has a significant plaque burden, but most of it is calcified, how would you treat their risk?
Yeah, I think that's a really, really great question. Like, you know, when we had our prevention program, when I was still at Cornell and New York Presbyterian Hospital, we told the patients, like, we have 2 goals here, not just one. The first is that if you have 100 units of plaque, we're going to keep it at 100 units of plaque. And that means we're going to stop new disease progression from forming. But the second is that if the horse is already out of the barn and you've got a tremendous amount of plaque, what we're going to do is we're going to try to stabilize the atherosclerosis, and everything we understand from medical therapy, lifestyle interventions such as the DASH diet or increased physical activity, is that those endeavors transform the morphology of plaques from dark to bright, or from non-calcified to calcified. Even within, I know that as a field, we tend to binarize things, right? And say that we either have non-calcified or calcified plaque. But as we have seen, there's different phenotypes of non-calcified plaque. You've got the low attenuation plaques, you've got the more fibrous plaques and things like that. Similarly, there's different phenotypes of calcium as well. That was proven in a study that was published in JAMA Cardiology about 2 years ago, where they looked at the Hounsfield unit densities. And once a Hounsfield unit density reached 1,000, those plaques were actually associated with a lower rate of myocardial infarction rather than a higher rate, as compared to non-calcified plaques and lower density calcified plaques. So, you know, that's part of the goal, is what we have told the patients, is that like the transformation of plaque morphology is a sign of stabilization, and that sign of stabilization is associated with a reduction in major adverse cardiovascular events. And so if somebody has purely highly dense calcified plaque, I think that's it appears based on the literature that that is a sign of stability, not of risk. That said, I think you still treat their risk factors as well, like you don't ignore that. So I think from our standpoint, like when we had our prevention program, we focused more on disease burden and disease type, utilizing the non-invasive CCTA. But we never ignored the risk factor control, right? So if somebody had elevated lipids or pre-diabetes or pre-hypertension, we were always aggressive in that treatment as well. But suffice it to say, just in summary, we used to tell the patients that there were the two goals, like 100 units should stay 100 units over time. That stops new disease progression. And then dark plaque should turn bright over time as a mechanism of stabilization after medical and lifestyle therapeutic interventions.
So Jim, I think everybody understands the concept of burden, and that the more plaque you have, the more significant that may be for you. But how do you temper burden with actual classification, right? Because you could have the same volume of plaque, but have very different phenotypes. And so how can we advise folks in terms of how they may look at treating their patients in situations where, like, there may be the same burden, but there's different phenotypes, and on that, do you think the staging system will change over time to include some of those characterization issues?
Yeah, I think that's a great question, Jay. Like I guess you gave the earlier analogy to cancer and how we stage all the cancers. And that was really a step forward, I think, in terms of us being able to standardize the approach to understanding how sick somebody is. Just because you have high cholesterol doesn't mean you have a lot of coronary disease. And just because you have low cholesterol does not prevent you from having coronary disease. One part of that lecture that you gave with the staging of the cancers, I think that the next step is the classification of the cancers, right? So we always do staging and classification. In the case of cancers, it's typically sort of either a genotypic or it's like a pathophysiologic classification of, do you have small cell lung cancer or adenocarcinoma of the lung? Or you could do a genotypic marker. Are you HER2 positive breast cancer or estrogen receptor positive breast cancers? In coronary disease, it's such a polyfactorial disease, right? It's environmental, it's genetic, it's situational, it's thrombotic, it's inflammatory, and so on. So I don't think one gene is going to be able to classify the type of coronary disease that you have. But I think what has come about in the last 5-6 years really is the phenotypic classification of coronary heart disease. And meaning that, are you really, really dark plaque and low attenuation and fatty and cholesterol filled? Are you sort of dark and non-calcified and fibrous and scarred? Are you calcified and turning into sort of a rock and turning bright? Or are you really, really bright white and highly dense, sort of 1K greater than 1,000 Hounsfield unit densities of plaque? And what we've witnessed, at least in the literature, is that all the salutary things that we do for patients take those really dark plaques and move them into a brighter category. So rather than, I think, these sort of overly simplistic classifications, I think we should think of this process as continuous, that if you put somebody on a medication or they change their lifestyle, just getting things brighter seems to be associated with improved outcomes. And so I think that's one way you could sort of start to think about classification of coronary heart disease, with the phenotype of plaque, rather than simply just saying, is there a lot or is there a little?
I understand. The next question actually sort of plays on that a little bit from Dr. Leal. With calcium, we found that we could analyze progression over time, but time in between scans was variable, 1 to 5 years. Looking at plaque stabilization of soft plaque, what do you recommend, or what recommendations do you look for follow-up scans post-therapy? Jim, I'll let you answer that one too, if you'd like.
Yeah, that's a really good question. Like, I mean, the examples that we gave are like, let's say you have somebody and they undergo a calcium score, a non-contrast calcium score, and their score is 250. And you ask the question, is this person sick or not? I think the knee-jerk reflex response would be, yeah, of course that person's sick. They've got an elevated calcium score. But what if I told you that this person was an avid exerciser and a multiple marathoner? We know that those two things increase your calcium score. Or what if I told you that this person had gout and excess uric acid? We know that that increases your calcium score. Or somebody on dialysis, we know that increases your calcium score. Or somebody who was treated with statins for 5 years, we also know that increases your calcium score. So it's a hard metric to follow, right? And it's also a hard metric to gauge, was that person treated before, either through lifestyle and medical therapy, in such a way that the calcium score became 250, or is that 250 representative of an overall high burden of atherosclerosis that includes sort of the more high risk, low density or non-calcified plaques? And we simply don't know. I think what Dr. Leal is asking is like, how often would you consider evaluating these people? And so I know that this paper that Jay had alluded to is espousing a 4-3-2-1 approach, where you don't advocate to do annual evaluations because it's just too frequent, and it's probably not a judicious use of healthcare resources. But this 4-3-2-1 approach, instead of saying, oh, how often on a regular clip should we be doing imaging, it's using the disease burden and stabilization as a guide as to when you should be able to stop. So the 4-3-2-1 approach says that if you're completely normal in stage 0, then don't come back for at least 4 years. We know that atherosclerosis is an insidious phenomenon. We know that the warranty period of a completely normal CCTA is very long. And so there's just no need. But if you've got mild, moderate, or really severe, coronary heart disease burden, then maybe it's time to consider coming back in 3, 2, or 1 years respectively, just to make sure that the treatment medications and lifestyle are actually working to, 1, again, stop new disease progression, and 2, to stabilize the disease that's present by the plaque transformation of the morphologic change of darker to brighter. Once you have clear-cut evidence that like you have stopped the disease burden and that you're stabilizing the plaque already present, I think then you can stop, because you know what you're doing is working. And so, but I think if we get into a situation where we're trying to do annual scanning on people, I think that's just excessive, and it's not a great, it's not a judicious use of the healthcare resources. So we should be very careful about it. And I think that we also need some studies moving forward to validate this whole concept, because what Jay had talked about is a very, very new approach or paradigm to cardiovascular disease prevention, and that's there's still a lot to learn.
Yeah, I think the ability to track the totality of disease is what sort of sets QCT off from calcium scoring. With calcium scoring, if your calcium score doubles, you don't know whether that's because all of your plaque is progressing, including your calcified plaque, or in fact, the therapy you're on may be doing exactly what you want, and you've converted an equal amount of soft plaque into calcified plaque. So in fact, you could look at a doubling of your calcium score in two different ways. It could either be successful therapy or it could be therapy failure. So which is why I think in general, it's not used that much for disease tracking. Certainly it's used for the establishment of disease presence, that it's there, but it's not necessarily as helpful for disease tracking. Whereas when you're tracking with CT angiography, you can both look at the calcified plaque, the non-calcified plaque, as well as then the necrotic core, the very low density plaque, and see how all of those are responding over time. So we certainly have seen very nice examples of, regression of disease to somewhat, as well as stabilization of disease, as well as unfortunately progression of disease with our ability to, compare one study with the next.
What's interesting, Jay, is that in the paradigm study, that was done with statins versus no statins, what you saw was that the statins slightly slowed the progression of disease, but not by very much. The p-value was barely significant at 0.04. But what you saw was that there was an increased calcification in the statin arm and a decrease in the non-calcified plaque. And those were highly statistically significant. And so that's great when you see that figure, but then when you sort of see it in actual life, it's even more eye-opening. Like I saw a patient scan yesterday where it was 4 years between their two scans. In the first scan, they had 220 units of plaque, cubic millimeters, and then in the second scan, it was like 225. So it was almost static. So the new disease had stopped, the progression of new disease. But what was interesting was all the non-calcified plaques went down and all of the calcified plaques went up. And so it was just remarkable to see sort of that paradigm figure that was in the Journal of American College of Cardiology, and then to see it actually on an individual patient work exactly the same way. And I say it like it's a surprise, but Jay, you and I have seen just time and time again these kinds of changes in the individual patient where you just feel very strong about convicted about the therapeutic regimen that you're using, because you're like, this is fundamentally working, and I've proven it quantitatively using the actual disease rather than indirect surrogate markers of disease.
Yeah, it's truly personalized heart disease care, diagnosis and therapy, where you know exactly what your patient's phenotype is, then what the patient's risk may be based upon that, and then you can also observe the success or potential failure of your therapy by following them over time. So rather than just following a surrogate marker like a LDL level or some other marker, for the first time now, we actually see the disease. We see the success of disease, which can be both enormously gratifying for both the physician and the patient to see, and can certainly help with adherence to therapy over time once they see that it's actually working, or perhaps once the patient sees that it's not working and their disease is still progressing. Well, maybe then they'll really start to change their diet and do other lifestyle changes that they have not been as adherent to before. But I think once a patient starts to see their own plaque, see it, which direction it's going in, that can be very highly motivating for them.
I think you're exactly right, Jay. Like I was thinking about why are we so obsessed with like the Fitbits or the leaderboard on Peloton, or it's because you want to see improvement over time. And now we have a quantitative way that the patient can see improvement over time without waiting to have a heart attack or without waiting for the silence of not having a heart attack. But there's demonstrable quantitative approaches to do longitudinal disease tracking. I also remember like a few years back, like I was just watching, there was a TV commercial that came on and said, if you're PD-1 positive, you may qualify for Keytruda. And I thought, gosh, like it had been a while since I trained as a medicine resident. I'm like, when did that happen where we had such personalized therapies to cancer? And what I think we are having with CCTA is this ability to truly personalize heart disease, as you said, to deliver a precision heart care paradigm rather than a population-based one.
And we're also armed with much more weapons now than we ever had before. 5 or 10 years ago, we had very few medications that would affect plaque. And now we have, I think I lost count at 12 or 14 of them that currently will show, beneficial plaque changes and reduction in risk by the way that these medications will interact with plaque. And actually, the next question is along those lines, Jim. It's about statins in women. I think we see a phenotypic difference in women compared to men, and then perhaps you can comment about the use of statins in that population.
Yeah, I just, before addressing that, I'll go back to the comment that you just made. Like, I mean, I've heard probably at least half a dozen times this year where somebody says, well, I put him on a statin, like what else can I do? Well, I'll point to two items. Like, one is a beautiful editorial that was written by Peter Libby and Jack in sort of the mid-2000s, where he talked about the forgotten majority, where we put somebody on a statin and then we reduce their LDL cholesterol, and yet there's only a 20 to 25% relative risk reduction. What that means is that the forgotten majority, there's still an 80% residual risk, but we don't know who's at risk, right? Because we've lowered the cholesterol. So but the statin is only 20 to 25% potent in terms of reducing the risk. So there's a lot more we can do with statins. To Jay's point, like the question of what, I put them on a statin, what else can I do? Well, I'll just enumerate them, like Zetia, aspirin, rivaroxaban, bempedoic acid, PCSK9 inhibitors, icosapent ethyl, inclisiran, colchicine, GLP-1 receptor agonists, SGLT2 inhibitors. You know, we're going to have GIP, GLP-1 receptor agonist hybrids coming soon. There's 2 lipoprotein a lowering drugs coming out. Like, so compared to sort of the drought of coronary disease medications 5 years ago, we've got a toolbox that is so heavy, we just don't know who to treat with these blockbuster medications. And so I think a personalized approach to doing so is probably the most effective. I think that speaks exactly to Dr. Glow's question about statins in women specifically. So for that, I'll take you back to a couple of studies that utilized machine learned algorithms to identify risk. And whether it was risk of a heart attack or major adverse cardiovascular events, or risk of being a rapid progressor, or risk of a vessel being ischemic, if you do all of this atherosclerotic characterization and really understand it across the entire coronary vascular bed and the different phenotypes of disease that are present, and you ask the machine learning algorithm to output in rank order the top 20 features, what you'll see from those studies that had been published is that all the top 20 features are disease features. They're like how much plaque you have and what type of plaque you have and how far is it from the ostium. And all of these things sound like I'm ignoring Dr. Glow's question, but I'm not. And the reason I say that it's the top 20 features are disease features is because what isn't in the top 20 is, are you a man or a woman? Are you old or young? Are you black or white? Like, by personalizing the care, we can democratize the care. I think what Dr. Glow is alluding to is that we don't understand women's coronary vascular biology the way that we do with men, and because most of the trials that we do are dominated by middle-aged white Caucasian males. And so by getting to the individual, like looking at medicine as an N of 1, now you get rid of all of the biases that have been associated with the large-scale trials that have tended to enroll predominantly, one type of patient over another. I don't know if that answers Dr. Glow's question or not.
We still have a few minutes remaining. If anybody has any additional questions, you can. Dr. Glow did acknowledge you and said, yes, thank you, Jim. If you have any additional questions, we're happy to hang on for a few minutes to answer them.
What I might do, Jay, is just try to challenge the group and say, like, look around at the most successive preventive care paradigms in medicine. I think that they've mostly been in cancer mortality reduction, right? So if you look, 20 years ago, we were recommending to women to do monthly breast exams. That fell off the wayside and has been supplanted by 3D mammography and digital breast tomosynthesis. 20 years ago, we were taught to check for blood in the stool, and that was supplanted. Now we do routine colonoscopies, and same thing, like with chest x-rays and now high-resolution lung CTs. If you look at all of the most successful paradigms in healthcare, where we've really made a dent, it all uses advanced non-invasive imaging to do direct visualization of pathologic disease, right? Like if I gave you a tool that could only look for fibroadenomas of the breast rather than adenocarcinoma of the breast, that's not useful. In my mind, that's sort of the analogy between calcium scoring and CCTA, is that it allows you to see atherosclerosis, but what we understand from the literature to be intrinsically stable atherosclerosis, not a high-risk atherosclerosis. So I think that leveraging an advanced non-invasive imaging modality that allows for truly quantitative assessment of pathologic disease really does emulate the most successful preventive care paradigms. And I think that's the direction that the field appears to be going.
And it also continues then with follow-up. You know, I mean, any cancer that's diagnosed and treated, we don't stop looking at that point, right? You know, you continue to look to see the efficacy of the therapy that the patient is on, and if it's cured or stabilized, then you then follow the patient serially for the rest of their lives, generally, to make sure that the cancer is under control or doesn't come back. And that's really the same paradigm that we think for coronary atherosclerosis. No one is ever cured of coronary atherosclerosis. All you can do is stabilize it or maybe even regress it a little bit, but you will still have atherosclerosis for the remainder of your life. And at any time that, you know, it needs to be managed for the rest of someone's life. So just looking once and picking a therapy and, you know, crossing your fingers and hoping it's successful is not going to be as successful as looking to see what the therapeutic response was, and then of course tracking the patient over time to see how they're doing.
Yeah, Jay, I would just add on top of what you said is that, you know, when I was training as a cardiology fellow, like what we were taught was that people who are at risk are patients with symptomatic angina. And what we need to do is treat that angina. And by doing so, we can reduce the symptoms and reduce the risk. But what we realized is that we were wrong. We were conflating two questions into one. There's the question of symptom relief and making somebody asymptomatic, which is an admirable goal. And then there's also the goal of reducing heart attacks, which is the more, it's the #1 public health epidemic that we're facing as a world today. So if you look at all of the trials that were done, whether it was Courage or Orbita or Berry 2D or most recently ischemia, what we've learned is that by conflating those two questions, we actually sort of missed out on probably the more important patient-centric outcome, which was the heart attacks, where when we take symptomatic patients with ischemia or angina, we treat that, we can treat their symptoms, but we don't actually reduce their risk of major adverse cardiovascular events. That's why I think you need to extricate those two. When you looked at John Ambrose's data from the 1980s and even the iconic data from a couple of years back, what we found was that more than 3 out of 4 lesions that will cause heart attacks do not cause a significant stenosis. So then why are all of our tests just aimed to try to find the severe stenosis when 60% of the people who will show up with a heart attack have no symptoms, and 75% of the lesions causing heart attacks don't cause stenosis, symptoms, or ischemia? There has to be sort of a recognition that we're fundamentally asking 2 questions, not one. And the paradigm that we've used in the past doesn't address the second one, which is how can I reduce the risk of heart attack in this patient? And to me, that's generally a medical therapy and lifestyle interventions problem. But I would posit to guess that there are probably millions of people out there just walking around ostensibly asymptomatic with severe triple vessel angiographic stenosis and left main stenosis who really need more aggressive interventions. And so rather than sort of having this arbitrary dichotomy of symptoms versus no symptoms, I think we should just focus on disease burden, disease type, and across the continuum of whether you're asymptomatic or symptomatic.
Yeah, certainly agreed. We need to identify the people who are at risk, and those who are at risk, we need to understand how much and what type of disease they have, and then treat them based upon their phenotype of disease. Okay, well, I think we're at the top of the hour, so thank you, all of you who logged in, and thank you specifically those who offered questions, and we'll thank the Society for sponsorship of the webinar, and we look for all of you at the AI Symposium at the SCCT this summer.